Now from the complex to the simple, and I'm going to present to you a fruit of the aortic intervention. So we have been, actually this came up by chance. I have been, like all of you guys, interested in the complex. So whenever I heard about the PEARS procedure in the last few years, I just said, well, there's no place for this. Why do I need to do this? And I was quite skeptical about its place in treating patients. First of all, I said that it couldn't be possible without my wonderful team, and I have to thank them all for supporting and helping, because bringing anything new to Waikato or New Zealand is a huge challenge. And I have to thank Nick particularly, who is the one that brought the technique here, because he saw a patient in the clinic, and as the patients do, and you can see this is clearly a Marfan patient. The patient have done a search on the internet and find out that there is a solution to his problem that the surgeon didn't speak to him about. Nick said to him, I'm going to do a Bintel operation or David operation, and the patient stood up and said, look, there is another operation they do now in London and in Europe, and I think it's safer and it is better results than the one you do. So can you do it? And Nick said, oh, I'm sorry, but I know the surgeon in London who does them, and I can refer you to him. The guy is a business owner, and in the face of it, he said, oh, the money is no option, I'll go. So I think Nick rang the Brompton Hospital, spoke to John Pepper, who's one of our colleagues in London, and told him about the situation. And then the patient was given an estimate of how much it's going to cost. And suddenly, of course, he retreated back. Oh my God, this is too expensive. And can you do it here? I said, we can't. He said, why if I bring the surgeon over from London to New Zealand and you guys help him to do the case? So anyway, that was the start of it. So basically, the patient initiated all this. The patient collected the money. He had a website asking for donation, so he didn't use his own money too. And collected the money to buy the prosthesis, to pay for the surgeon to come over from London to here. Nick kindly housed the surgeon and fed him while he was here. And we thought about it carefully, and I said, okay, then there is no experience of doing one case. So if the man is coming all this way, we might as well get a few more patients and discuss with them the possibility of doing this, and we should have a Marfan guys to do this. So I have some challenging cases, and I will show you what cases we chose for this. And I thought, well, what the worst can happen? Just convert the PEARS, if anything goes wrong, to our primary David one, and we told the group of patients, if we can put this wrap around and anything goes wrong on the day, we're just going to end up doing the conventional operation that we usually do for this. So just for the audience and some of our junior colleagues, when you have a root pathology, particularly Marfan, you're dealing with coronary arteries, you're dealing with aortic valve, and you're dealing sometimes with the ascending aorta. Now, Marfans in New Zealand, there is a small number of families and patients who are affected, but what is surprising to me that the majority of the patients with root disease are idiopathic. I don't know what the cause for it, and it is many of them. There are a huge number for a small unit like ours. We see, or we do at least 2 Bentals a week. Now, I just don't know where they come from. The number of Marfans are small, and definitely atherosclerosis of the ascending aorta in New Zealand, again, is very rare. And probably the reason is the origin, the anatomical origin and embryological origin of the aorta. So the root originates from a different set of tissues than the rest of the aorta. And at the end there, you can see on the right-hand side, the abdominal aorta. Most common aneurysm there is atheromatous. And that's again in New Zealand is very evident. So we have a lot of New Zealand patients with atheromatous abdominal aorta. And this is a histological cut of the idiopathic one. You can see the intima is normal. The problem is in the media and the adventitia. And that will lead me to what I said to you. I hope that plays. Now, for the guys who don't see it in theater, this is the ugly. So this is an idiopathic, typical, Thursday case with Brian. and you can see the blood is swelling down the root. This is also a problem for us, that the patient comes with this kind of chest, and they take their shirt off and say, whoa, what am I going to do now? And would we repair the chest before we do the sternotomy, and then do sternotomy and disrupt the repair? What would we do, and how do we access to the heart? And there is worse. This is my worst patient. So this one agreed to come for the PEARS procedure and said, I'll give that to the proctor. That would be a great case. You can see that, we have a problem. And this guy had many rods in his back, and he said to me that whenever he went to hospital for a simple procedure and lie on his back for about 5 minutes, he gets ulcers from the pressure of the metal. Again, it's the thin skin. And in the front, I've never had that as well before in my life. I put my finger in that little hole there, and I can reach his spine. So, I thought, bloody hell, what am I going to do with this one? How am I going to approach the heart? The heart was completely gone into the left chest, and the aorta is in an abnormal position. Now, I'm sure all the surgeons in this room, aortic surgeons, have faced this and have used this technique occasionally. So I have this old book, and I was lucky to sit in a dinner with Denton Cooley in his late years, and he signed that book for me, and I probably keep that because it will be worth a lot of money as the time goes on. This book is a fascinating book. It's the early times of aortic surgery, where actually it was pretty tasking and difficult feat to get into. With the new technology we have now, life is a little bit easier. But for those guys, really, it was very difficult. And in some patients, an 80-year-old who you accidentally open to do something on, tissues are fragile, and you might back out from replacing the aorta. We used to do the Cooley wrap. And the problem with the Cooley wrap that, doesn't fit very well. It's difficult to put around the aorta precisely, and it migrates no matter how tight you do it. And the material we use is the usual, either a graft that we fashion ourselves, or something that, like the bottom here, use a few separate strips. Now, I think, the idea, which the engineers have done, and we'll talk about it later, come from the material that's available to us now. So the PEARS grafts are made of elastic material, and I don't want to dwell on that because that's tomorrow. The other thing I've learned that when we're doing the procedure for Marfan, not all the Marfan roots looks the same. They are not the same shape or size. So you can't really have a graft off the shelf that will fit them all. So having to think about a graft that is made for the patients particularly to fit the root is an ingenious idea. So what's the advantage? You can do it off pump. There's no transfusion, shorter operating time, and it can be done through a small incision, which I have done for the guys that were difficult. And just as a quick sort of the first patient, so a little bit more than hemisternotomy. So I stopped where the hole started. And I think in the beginning, I realized as well that's an operation not for the faint-hearted, and you will see in a minute why. So we'll lower the blood pressure, and now we're trying to get around the roots. And you have to go as low as the dissection for a proper David operation. Otherwise, the graft will be useless. So you have to go below the coronaries. You have to dissect everything around the root and go as low as you can, so you can put the grafts well in a place that it will hold the root together. Otherwise, there's no point in doing it. And the dissection is not easy, and it does take 2 senior surgeons, to be honest. Even the retraction, you can pull too much and you can cause problems. So I think 2 experienced surgeons do this together to make sure that you don't get into trouble. And it has been good working with Nick on this for a while now. And again, you have to go around the left main. So now the graft tells you where the coronary origin is and particularly help you to identify where the left main is. And you keep going with sharp dissection and blunt dissection till you can get down far enough. And here, of course, if one makes a hole in one of the chambers, and when I do David, occasionally I open a right ventricular outflow tract, and I have to put a stitch. But with this, if you do, I think it will be a different procedure altogether. So really taking my time to do this. No rush, just gently dissection. And I think it's more stressful than David one for me, this operation. I haven't really got comfortable with it yet. And then going around the coronary, this is the left main. So you have to have enough space underneath it. And you do the same with the right coronary. So I've got it really from both ends, quite isolated and nice and clean. And there is the distance below it is the distance on the graft. And then now you make a hole for both coronaries. And I speeded this up so I can cope with the time, but I'm sorry about that. I have to ask David, not me. So now you unravel the graft. It's very flexible. It's very soft. And you mark where you want to do the cuts. And then this is the cut to the coronary on both sides. This is the bit that is going to go below the coronary and is going to be at the annular level, the same as your David graft. And what holds it down there, its elasticity is quite tight once you suture it together. And that bit there again has to be done gently. And we dunk the graft in paraffin oil so you can pull it easily around the tissues because you don't want it to stick on anything and you don't want it to unfold. And again, you can see the experienced assistance is mandatory. Now this is going to go behind the right coronary artery. Which again in the Marfan patients is not hugely difficult, but one thing I've learned from the idiopathic patients that some of the patients, their coronaries are low and very low. And that to me now is a contraindication for doing a PEARS procedure. The low coronaries are not a good choice for this particular procedure. I'll still do David 1 happily on them. And once you do this, you close the gaps that you've opened, and you can tighten this as much as you like. And because of the way that is manufactured, the tissue grows into it. It becomes a part of the aortic wall. Within 6 weeks, it becomes the aortic wall. So you can go back and cut it and open and do an aortic valve if it is required. And this is the end result. You end up with that sort of shape. The follow-up, which we have done so far, has been great. But every graft they send you 2 sizes. One 95% of the size of the root, which I usually use because the idea is to reduce the size of the root. And all the roots I have done, which I've done 11 now, have managed to reduce the size by 25%, which is quite good. And I have also the 100% size graft. Now, these grafts are 100%. We didn't waste them. We started using them to create a landing zone for our vascular surgeon around the ascending aorta. So they wanted to put, and I did this week 2 or 3 patients, they wanted to put an arch in the graft. So I do Matalanis deep branching off pump and put a wrap around the ascending aorta and reduce the size below 3.5 centimeters so they can land whatever they want. These patients recover very quickly, don't need blood transfusion. You can do it through a small incision. And again, there is a place for it. And I start to enjoy that bit of, doing that bit of operations. And as long as you keep the blood pressure reasonably on the low side while you're doing all your manipulation and you avoid, harassing the aorta too much, I think it has been really good. And I think there will be future to that intervention. Vasu probably will talk tomorrow about some of the application for this. And thank you. It's not all fruity.
Is there any fixation to the annulus?
It's a very good question, George. When you know how thin the tissues are there, so I put when you suture the bottom, because it shapes like the root itself, it doesn't move. Once you suture the bottom part of it, it just sticks around the annulus. It doesn't move. So in one patient, which was a redo, and that's probably a learning point, who had a mechanical valve in, and he came back as a dilated ascending aorta. And I thought, I can do this. And I put the graft, and of course the mechanical valve is a rigid annulus, it's not like the normal annulus. And the second post-operative day, it slipped off the rigid annulus and pinged on the right coronary. I think left coronary, right coronary, yeah. It pinged on the left coronary, which was low. And the patient had ischemic changes on the ECG. It was hemodynamically stable, but I didn't like the look of it. So I took him to the cath lab. It shows that the circumflex is compromised. I took him back and I did an off-pump graft to the circ, and I cut the graft open at that bottom and I fixed it with stitches to the annulus. So for the ones that have normal annulus, it doesn't move. But if you do it, if there is a valve in place or some other reasons, you probably need to fix it to the annulus because the movement would be too much.
Patients that may be prone to developing annular dilatation in the future and getting aortic incompetence from that.
Yeah, for the follow-up, the longest one is now 13 years, and there is no change in the aortic competency or the annular size. I think because the graft goes like at the bottom, there is a very thick part of it that goes around the annulus. It's like an annuloplasty ring that people are advocating, and it is low down in the level of the David 1. So there's an annuloplasty ring around the annulus. I don't know what will happen in the long term, but for the 11 years follow-up, there is no change in aortic valve function in the patients who started with that. So,
Adam.
Yes.
What is the idiopathic patient?
What is the idiopathic patient? I don't know.
Because every time there is the aneurysm of ascending aorta, we have many types of the same lesion. The same lesion is medial necrosis, aortic medial necrosis. We have 7, 8, 9 types of medial necrosis. Naturally, the bed is Marfan syndrome, Ehlers-Danlos loss, etc., etc. The fibrillinopathy. Okay? In all these cases, the indication is to remove the aortic wall, because the aortic wall have a disease. If you put outside the prosthesis, remain the aorta.
Right, I'm not arguing with that. I will tell you tomorrow we'll talk about the science behind it. But what I will say to you that if you put an outer side layer and the aortic wall is separate, so you have two walls, you can't achieve anything, because what will happen is the aortic wall will continue to dilate and be problematic. The idea with this one that you are changing the aortic wall because you're giving it another layer that becomes an integral part of the aortic wall.
Yes, but the rupture is the intimal part, and the lesion is in the media part, not in
I will show you tomorrow why it is unlikely that it will be a rupture or dissection. I think it's in a full lecture.
Adam, I was a skeptic about all of this, for sure. One of the guys that was involved in designing this and bringing it into clinical application is Tom Treasure, who actually became a thoracic surgeon, but he's a bit of an academic guy. I was sitting having a beer with him before the EACTS meeting in Milan, maybe what, 3 or 4 years ago? And he just got a post-mortem and histology report on one of the first guys they did, that was a Marfan guy who'd been killed in a road traffic accident, okay? And the histological analysis of the aorta, it had completely transformed from a Marfan's. Honestly. And it's only one case.
Yeah.
One swallow doesn't make a summer, but it was remarkable. So something about changing the wall stress within that environment has led to a remodeling and a completely different histological change in the aorta.
I think I wrecked my brain to understand some physics and some engineering principles. So hopefully there's a lecture coming that we will discuss.